Welcome, everybody. It's great to have you all. Got a wonderful turnout this morning. Thank you. And I have to confess, this is you're assuaging my anxiety by being here today. We've got Danita and I have had the honor of working with many of you, or all of you actually, during COVID, and we're at a new place where we're going to have to get testing set up in all likelihood. And so I know a number of you are really questioning, what do we do? How do we do it? Where do we go? And so the last thing I want to happen is us to get to January and you don't have a plan and you haven't gotten your test reserve and you haven't gotten other things done. So in that capacity, I've been interviewing and talking to different testing companies across the United States and trying to figure out what are the options. Because when the mandate was first announced, I had called up and talked to several people, and there were no tests available. People couldn't get them, and so it was really looking like it was going to be a train wreck. And one of the people that I had the honor of speaking to was Dr. Pinkney. That I'm gonna go ahead and turn the slides on now so you all can see those, and then I'll make introductions and we're going to jump into the presentation. Okay, here we go. All right, so boom. All right, thank you. All right, so let me go ahead and introduce, it doesn't matter which order, so I'm gonna go ahead and start with Dr. Pinkney. I've known Dr. Pinkney now for a number of years. My daughter actually went to the same residency program that he went to, and he interviewed her for a job coming out. So I got to reconnect with him back when she was just getting ready to go into practice. But Dr. Pinkney trained in family medicine ultimately, came out into the marketplace and really saw that the way that primary care was being practiced wasn't the way that we could really help people the most. And very quickly shifted to a DPC concierge type practice, which of course had him get to know corporations well and study and understand the dynamics that are going on there. He now has established a kind of a executive wellness aspect to his practice with a lot of proactive integral health, mind, body, as well as other cutting edge technologies to help people live longer lives, and in doing that to work with corporations. So he and I are very, very much alike in our paths, and he's done a fantastic job, which led him to start to do the COVID work at the beginning of the pandemic. And he probably has more experience than any other person I've spoken to with testing across the United States. So in setting this up today, I asked him to come on, give us a history, and then also to tell us where we are now, what the options are, what some prices are that you all should be thinking and looking at, what you can expect when you talk to companies about testing. And of course, if there's any interest in speaking with him afterwards, we'll make sure that you all can discuss it with him, because he is obviously very, very competent. The second person that we have the honor of having on the presentation this morning is Joellen Whitney. She and I have been working together again all during COVID, and she is by far the most outstanding, entertaining lawyer probably I've ever met, but in particularly when it comes to COVID, she's just amazing. And so it's such an honor that she's been willing to come with us today. She practices in the area of employment and health law. She's the current chair of Employment and Labor Relations Department in her firm, with 30 years of practical experience in business planning, discipline, termination issues for employers. Her work includes representation of employers before various administrative agencies such as the EEOC, ICRC, OCR, DOL, and OSHA. And she frequently provides her clients with on-site training for all levels of employees, and is highly sought after for presentations on labor and health law. And as you get to know her today, you'll understand why. Joellen is AV preeminent rated by Martindale-Hubbell, which for the CEOs on the firm know that means that she is the highest rated lawyer possible within Martindale-Hubbell, and has been recognized by Chambers USA, Great Plains Super Lawyers, as well as Best Lawyers in America for her work. So Joellen was admitted to the U.S. Supreme Court Bar in March of 2018, and I really appreciate, again, the honor of having her here with us today. So that said, let me get back to the slides here, okay? And I'm going to go ahead and there are three major objectives that I have for today. First of all, I'm going to go over what's happening in the world, then I'm going to hand it over to Joellen, and then she's going to talk about where we are in this crazy situation with the OSHA, as well as some state laws and other things she'll go over. And then Dr. Pinkney is going to talk about the history of kind of testing and where we are and what to look for. So when we leave today, I want you to have three things in mind. One is what's the situation and when the timing is to the best of our ability to predict. Two is what are the options for your testing. And then three, hopefully, you'll have some resources that if you need to pull on, you'll have expanded bench here that you can go do what you need. So as an introduction, we all know what's happened with COVID. We had the first little bump in New York City when it came in back in March of 2020, and we went down into lockdown. Then we opened things up, and we saw the bump that came with the fall of last year as people relaxed and went inside. And this was the biggest peak, but we got the vaccination somewhere in December for most of the healthcare workers and through the first of the year. And really, it seemed like we were making great progress. Things were coming down. And then we had this last spike that went up. And I know this is all the countries of the world, but we had this last spike that popped up here in the summer, and things went down. So things are looking pretty good in the United States as we left summer, came into the fall, and things seemed okay. But across the pond, my son is in the Netherlands, as an example. They have 85% of their population is vaccinated, and they're having a huge spike. So last Thursday, they shut the country down again, which I certainly hope we don't go there. But 85% are vaccinated. Now, one nuance of that is many of them are AstraZeneca and J&J vaccinated. There's a relatively small number of people that are Moderna or Pfizer vaccinated. So it could be that and what the speculation actually is that the single dose vaccines are falling off in efficacy dramatically. And the only way to get that back is to go have them get another vaccine. And most countries are choosing either the Pfizer or the Moderna for the supplemental vaccine. So we see the spike in the Netherlands and the United Kingdom, which is 90% vaccinated, despite that. Now, the good news is that it's not nearly severe. And if you look at the death rates and the hospitalization rates in these two countries that are very vaccinated and compare them to other countries that are not, it's dramatically lower. This is almost like a cold and flu season. You may have 30,000 people die, which is what we have in the United States with the flu season every year, but you're not going to have 300 or 700,000 people die the way that unprotected COVID is. Now, Croatia is a different story. Croatia's vaccination rate is just a little bit below the United States. So in Croatia, and by the way, these are the Delta variant that we're seeing through Europe right now. In Croatia, we're seeing that the hospitalization and death rates are very high because they don't have people protected. So as I've said dozens of times to all of you on the call, there's two different diseases in the United States. There's COVID for the ones that are protected and COVID for the ones that are not protected. And they're two different diseases. One disease basically looks a lot like a flu and cough and cold season in terms of hospitalizations and death. The other one is killing 700,000 people in the United States right now. So it's dramatically different. So we could find ourselves in the beginning of the year following Europe's big spike, and again, in vaccinated people as they come down with COVID, and particularly in unvaccinated people, we could be in a place where people are at very high risk that aren't vaccinated of ending up getting very ill. So with that, I'm going to turn it over to Joellen, and she's going to take us away in terms of understanding from a legislative and legal perspective where we are in terms of the mandates right now.
Okay. Hey, everybody. Thanks for having me today. So the questions I get most frequently are, what am I supposed to do now, right? Everything's in a little bit of chaos. And so what am I supposed to do now? The first thing I typically tell my clients is that politicians and the media love chaos, right? If it bleeds, it leads. It makes good headlines. It gets people worked up, but that it's pretty rare for a business to survive or do well in a chaotic environment. And so we kind of have to step away from some of the speculation and kind of the red meat kind of things that they're doing, and really just focus on what we need to do to move through this process in a way that makes sense to us, right? So really what I think is probably most likely is that we do need to keep planning and moving forward. So we have 4 mandates. The first is the federal employee mandate that takes effect November 22nd. And we don't care so much about that because we just let the federal government take care of their employees. Okay. The next is the mandate for the federal contractors, and that's January 4th, 2022. It has a testing requirement, and the testing requirement certainly adds complexity to what you would do as an employer because you're going to have more record keeping, more time issues, that kind of thing. There are no regulations on the federal contractor testing yet. I mean, they kind of came out, they went back, so we don't really have the regulations on that yet. You have the OSHA ETS. So if you're not a federal contractor, not healthcare, but you have 100 or more employees, the OSHA ETS is going to apply. The regulation date is January 4th, 2022. As everybody already knows, the Fifth Circuit stayed.
Ryan is currently on a
The Fifth Circuit stayed the implementation of it, and then it went to the lottery and how they assign big federal cases. And so it went to the lottery, and that goes to the Sixth Circuit to kind of just decide all of these consolidated cases. OSHA made an announcement that it wasn't going to enforce the rule pending some kind of final disposition from the court. That doesn't really affect us sort of long-term in some ways, because that means OSHA is not going to enforce it now. When an ETS comes out, it's basically enforceable the day it's published. So OSHA is saying we're not going to enforce anything right now. We probably won't see anything by December 6th. That doesn't necessarily mean that if it survives the court challenge, that OSHA will push back the final deadline, right? So we don't know what will happen with that. I think they've put a lot of pressure on people, and they've currently said, we want you to continue moving through this, continue planning for this. So there's a possibility that they won't extend the final deadline, or if they do, they won't extend it by a lot. Okay, so you do have to take that into consideration. If you're healthcare, there's a separate mandate, CMS healthcare, that has no testing requirement. A couple people have asked me about federal contractors in the CMS. Will it be challenged or stayed in the same way that the OSHA one is stayed? It hasn't been stayed yet. There's certainly lawsuits, again, consolidated with the 6th district, but there are lawsuits on that, but they haven't been stayed. The one thing you need to remember with both the federal contractors and CMS is that it is different because they are payers, right? So you're getting paid by the federal government if you're a contractor. You're getting paid by Medicare, Medicaid under these healthcare ones. And so they have an ability to make more laws, more rules, that kind of thing. So the chance of those being gutted or stayed are probably a little less. The other thing that you want to think about with your testing needs, right, is that we do have return to work testing. OSHA, whether you hate the ETS or just mildly dislike the ETS, they did do a couple interesting things in it. One of which is that you can have a policy where if your employees get tested, they have to tell you. Right. So if they're out, let's say on a quarantine, but they get a negative test, they have to tell you. So that's maybe a change to your communicable disease policy, but that's also going to put a burden on them and maybe a burden on you if you're trying to get them back more quickly in terms of testing. And then also if you maybe are not a federal contractor, but you're a sub, or you have special federal projects, that may put you under those federal contractor rules as well. And then you're going to have those testing requirements for that. Dr. Connor, can I have the next slide? So it's been consolidated with the Sixth Circuit, as we've mentioned a couple of times. And so we're in the wait and see mode. Not so much for CMS or federal contractors, because the magic 8 ball, right, basically says that's likely to go forward. Kind of wait and see on the OSHA ETS. OSHA doesn't have a great track record of supporting the ETSs through history, but we're just going to have to wait and see. I do want to talk just very briefly, though, about what the OSHA testing requirements are, because they're very extensive. So if I could have the next slide, that'd be great. Yeah, there we go. So if you have an employee who is not fully vaccinated, so it doesn't matter if you're just going to run a program where we're not going to vaccinate people, or if you have exemptions, so they're just not vaccinated, they're going to have to test under the OSHA ETS. The OSHA ETS would require that they test at least once every 7 days. And then if you have people who work remotely, they have to test before returning to the workplace. So this language that you see on the PowerPoint slide, this language is actually taken from the statute and then also from OSHA's sample policy. So you can see that there's a pretty significant testing requirement. That type of thing is going to do a few things, right? One, if you're administering it as an employer, you're going to need a process, you're going to need a program, but you're going to need access to supplies. 2, you're going to have to decide where and how you're going to do it. They have to be proctored, right? So I can't just send somebody home to stick a swab up their nose. They have to be proctored, right? So you need to think about that. And you also have to keep and maintain documentation for the length of a program. And so that's another component in testing. You have to think about it sort of start to finish and how you keep that documentation as well. And then Dr. Connor, can I have that last slide, the next one, please? If they don't provide documentation of the test result, you have to send them home, which means you have to have that documentation. You have to keep it. If you're using, a different process, a different clinic or someone to do those kinds of things, you're going to need the documentation regardless. And then again, as I said before, this kind of return to work sort of issue, if you have people that can come back early, maybe it was a false positive before, they don't have any symptomology, that kind of thing, then you're going to want to think about where testing fits in there as well. So the upshot of all of this is that regardless of what else we do, you do need to know who is and is not vaccinated in your workplace, because it's unlikely that OSHA would step away from masking or heightened masking requirements. They never really have, neither has the CDC. For those who are not vaccinated. So you do want to know who is and is not, so we know how to enforce our PPE, but you also want to be planning for these because they're complicated, right? It's a lot of testing. It could potentially be a lot of people, and you're going to need to have that process in place. So we're not chaotic, right? So we're not falling into that trap.
Perfect. Well, thank you so much. By the way, on the logo up on the upper right, this is your logo, is that correct? And what are the 2 Japanese, I assume it's Japanese characters?
It's basically moving forward is what it means. It's like moving forward. And so we're part of a larger network, which is Denton's, and we're called Denton's Davis Brown. So.
All right, got that. Thank you for explaining. Well, what we're going to do now is we're going to shift gears, and I'm going to ask Dr. Pinkney to walk us through where immunizations, where testing has come from, where we are today, and what you all can expect going forward in terms of the putting testing programs in place, which again, it was just a month ago. I will tell you, I was on numerous phone calls with labs all over the United States, trying to hustle to figure out how you all were going to be able to find people to do testing. And so it's really important that we get in the front of the line and we get things set up and not wait to the last minute, because it's going to be a disaster if we wait to the last minute and then try to come up with the exact program we want to follow. So with that said, Dr. Pinkney, would you take us away and tell us about testing?
Absolutely. Thanks, Dr. Connor. Can you actually go back to the slide where you were explaining the infection rates over the last year? That's actually a perfect representation of where I can talk about where testing has gone. So if you go back to March, I remember it like it was yesterday. We shut down March 13th, Friday the 13th in the US. And we have clinics in the Dallas Metroplex and associations all over the country. And it was almost impossible to get a PCR test. PCR is polymerase chain reaction. And that's where we actually take that viral RNA, denature it with heat, and then replicate it with a small sample to figure out if you had the COVID-19 coronavirus or not. Wait times were 2 to 3 weeks. Pricing was anywhere from $200 to $5,000. It was absolute chaos, and we weren't able to actually effectively test for COVID-19. Fast forward to June of 2020 is when the first EUA-approved antigen test came out from Quidel. And a viral antigen is something that's inside that viral nucleocapsid. And without getting into too much physiology, we basically lyse the cell with a chemical reagent, and we look for that viral antigen with antibodies, COVID antibodies that are on a test strip. So antigen testing became really prominent over the summer of 2020, and our firm, Diamond Health, we were able to get into COVID testing at that time. We did testing for 117 colleges and universities all over the country, as well as Major League Baseball. So the spike really, as Dr. Conard mentioned, really hit hard in this time last year, November, December. And at that point, there was a huge crisis with supply chain. We weren't able to get enough test kits. It was really challenging. We had lots of events that we were doing, and we literally could not get enough test kits to satisfy the demand. Once things calmed down, vaccinations rolled out, as Dr. Conard mentioned, then we had another spike in this past summer. And we kind of switched from analyzer-based antigen testing, which is very, very accurate, to point of care testing, which is less expensive, but not quite as accurate. And now, fast forward to October, November of this year, we really have changed from point of care testing, which requires a CLIA license, and so does PCR, and so does analyzer-based testing, to over-the-counter testing. So let's go to the slide that we had up here a few minutes ago, Dr. Connor. Here, so this is a graph of a chart of all the different kind of testing modalities that we find in the marketplace now. The three large companies and most reputable companies are Quidel, Abbott, and BD. These companies didn't just jump into COVID testing. They have a long history of producing different types of tests in the medical space, like strep, flu, and RSV. So we don't only look at price, but we also look at the reputation of a firm. Because at the end of the day, we're trying to rule out a deadly disease that could cause an outbreak in your office. So it's very important to consider who is making the test and the price. There's a lot of junk out there in the marketplace. There's a lot of product out there that from companies who have never made a test. They've gotten EUA approval, but they're kind of jumping into this to capitalize on the marketplace. And I just encourage you to be aware of those types of companies and buying product from sources that also aren't vetted and aren't reputable. So the first one on here, the Quidel QuickView Pro, is one of those point of care tests. So you can see on this graph that it doesn't require an analyzer, but it does require a CLIA license. And CLIA is a type of laboratory credential that is required to run these tests. CLIA waived is a misnomer. It doesn't mean that you don't need a CLIA license. It's actually the lowest form of CLIA certification. And all of these, except for the OTC tests that don't require a CLIA license, are CLIA waived. So we have set up labs inside employer spaces. We've set up mobile labs. We've done this all over the country, and we've done over 1 million tests in the last 18 months. So we've got a lot of experience. The antigen test, the Quidel Sofia SARS antigen test, the third one in this row, that was our biggest analyzer-based test. Most accurate antigen test, 97% accurate. I like that test a lot. The Abbott Binax Now OTC, Binax Now came out with the POC product first December of last year, and they charged $5 for it. It was, just destroyed the market. Everything back then was $25 to $35. The government bought, 200 million of them, and we really couldn't get any of that product for 4 to 6 months because the government bought it all. So it really didn't get into the private sector until several months later. So now the prices have come down dramatically from 18 months ago. You can see these are kind of the market rates for these items. I like Abbott, BD, Quidel. I like all of these things. We use all of these in our actual clinics, and we use these for our employer clients as well. They're all anterior nary swabs. That means it's the front part of the nose, not the nasopharyngeal swab, which is, I call that the brain biopsy, where you're taking a Q-tip and sticking it all the way up your nose. It's very uncomfortable, but these products can be done with an anterior nasal swab, so it's much more comfortable for your employees. And it's just a matter of which one do you think is best for your company. Do you want to go with accuracy? Do you want to go with just cost? I just want the least expensive test. You have to weigh all these factors when you're deciding what you want to implement. And we are still having incredible supply chain issues even to this day. We all know about the container ships that are stacked up in our ports. That's causing issues. There's distribution issues, logistics issues. So as Joe Ellen recommended, you really need to figure out what you want to do now, because whether or not this mandate stands, if it is implemented on January 4th, and you're not making a decision in the next 2 weeks, you are not going to have any test kits. And then that's a disaster. That's a worst case scenario. So that's really the point. Go ahead.
Yeah. So James, I know that you've seen many companies across the United States setting up different programs, as well as the experience you've had personally. What do you see companies doing? What do you see in terms of how many are you seeing that are saying, hey, we're going to do the home program, and they're supplying tests to people? Because I know there are companies that I've seen that's going to be their strategies. Other are hiring companies to come on site and do testing, Monday, Thursday kind of idea, et cetera. So could you share with us some of the actual on the ground strategies that you're seeing?
Yeah, so the larger companies are definitely still doing on-site testing. So firms can set up a CLIA lab inside some space in the company, whether they have a on-site clinic or not. It can be set up with regular employer office space. It doesn't have to be necessarily a clinical space for a CLIA waived lab. And they're hiring individuals to come in and do the testing. It's very efficient, and they can see the process right there. So that's the plus on having an on-site clinic. It's much more expensive than implementing, let's say, a virtual program that some companies are choosing to do, where, as Joellen mentioned, the test has to be proctored. So you can't just pass out an over-the-counter test kit, for instance, and have your employee take that test at home and report the result. So there are companies out there that do virtual testing, kind of like telemedicine, but you are actually watching and instructing your employee how to perform the test. And then we watch the test cure and make sure that the test is run properly. Then we have an EMR where we record the results and then can report those results to the employer so that it effectively meets all the OSHA criteria for a correctly proctored test. The other option, you have the OTC, the on-site, is sending your employees somewhere off-site to do the testing. And that's been something that has been implemented as well, but also very expensive. The least expensive and most efficient model is probably the virtual care model, where you buy an OTC test kit over the counter, which is the least expensive test kit. It's not as accurate, so you are sacrificing some accuracy with that. For instance, the Quidel OTC test is 84% sensitive or accurate, and the antigen test that we run on an analyzer is 97% accurate. Now, with that being said, the Quidel over-the-counter product is much more accurate than the Abbott Binax Now over-the-counter product, which is 62% accurate. So 84% accuracy for the Quidel OTC and 62% accuracy for the Abbott OTC is something you have to take into consideration with your program.
That really strikes me, James, that we're going through all these logistics. We're trying to make sure we do the right thing, to comply. But at the end of the day, it'd be nice if we didn't have a lot of our people at work get sick and have to go home. So if you were to the crosshairs of cost and efficiency of doing it and accuracy of testing, and you were to, we made you king for a day and you got to set up the program for the United States, what test would you do and how would you do it?
Yeah, great question. So if you look at the lead time column, you can see what tests are immediately available and what tests have a lengthy lead time. The point of care analyzer-based tests are ready right now, but you have to set up a CLIA lab. And depending on what state you're in, that could take months within itself. If you're in California, that's going to take 2 to 3 months, period, to get your CLIA license and to comply with all the regulations in that state. And we know because we've actually done many CLIA labs in California. So I would recommend the Quidel QuickView at-home OTC test, row number 2. It's got a great price point. It's got an 84% accuracy, and it's available in 2 weeks. So this is probably your best option, and pair that with a virtual care offering from a company that can do testing virtually, that has an EMR, that has a way for a dashboard for the employer to actually see the aggregated data, see who's negative, who's positive. We like the terms clear and not clear, so we don't get into some HIPAA issues with reporting on a diagnosis instead of a status, like can you come to work or not. And there's companies out there that have an all-inclusive solution that you can stand up in a few weeks, utilizing the Quidel QuickView OTC and a virtual COVID testing platform.
So Joellen, as you're helping companies work through this, what advice do you give them about the documentation, exactly what to do? Let's try to get really practical for the folks listening. What would you say, here's what the best way to do this is right now, given what we know? Joellen, you may be frozen. Yeah, I'm afraid she may be frozen right now. So I see that.
Looks like she's back.
Oh, good. Go ahead, Joe.
Okay, yeah, so it told me my internet connection was unstable and then it apparently, stabilized. So
So the
Did you
question
have
the question I asked you was, again, you're working with all these corporations and banks and things that you and I have actually worked together on, trusts, bank and trusts and things like that. What are you recommending in terms of practical, like do this now, set this up? This is the safest, easiest, fastest, least expensive way that I could recommend you attack this.
So do you mean just in the testing component?
Yes, just focus
Okay.
on the testing and reporting, I guess, would be
Right.
the two things that they have to do.
Right. So I think that you have to make a decision based on your business, based on what you're attempting to get to, right? So if you have an industry where you have extremely high COVID rates, like Iowa did, right? We did in our packing plants. We had extremely high COVID rates. You may need more accuracy, right? To make sure that your entire workforce doesn't end up out on the street and everybody has to pay, $100 a pound for pork chops kind of thing. So that may be important, but you need to sort of figure out how you're going to do it. If you're going to get someone, I personally, in my companies, which are not healthcare, see a lot of telehealth. Okay. So see a lot of proctored tests that are done electronically. And then for me, a big issue here is that you have the right documentation, right? So as Dr. Pinkney talked about, you can create this dashboard, you can produce those kinds of things. Whatever you do, we need to be able to keep and maintain that documentation because that's going to be critical. And I know Dr. Pinkney referenced HIPAA, but HIPAA applies to him because he's a healthcare provider, but it does not apply to your access as an employer to those test results. That's done as part of your employment process. So although you should treat them as confidential and all of the various mandates discuss that, it's not HIPAA per se, it's employment confidentiality. But Dr. Pinkney has, of course, much higher standards for that because he's covered by HIPAA as a provider.
So could you
Thanks
look
for
at
that
this?
clarification.
Yep. So on the second question, can you confirm if legislation does not mandate employers pay for the test? What are the most employers doing? Is a company paid, employee paid? Walk us through that.
Okay, so this is basically how do you make lawyers' heads explode, right? Literally, we are just basically a mess on the floor at this point. So OSHA particularly punted on this. I mean, they just said, we don't know what we're going to do. And they basically said there may be other state laws. So the payment issue will depend very specifically on your state law. In Pennsylvania, the Pennsylvania attorneys I work with think that the state law says you don't have to pay for it. So you wouldn't pay for the test and you wouldn't pay for the time. In Iowa, we have some places where you have to pay for tests, but other places like TB testing and healthcare where we don't pay. So we think it edges towards the not pay because of the traditional way it's treated in Iowa. For any of you who might live in California, pretty much you have to pay for anything, right? Pretty much if you're the employer in California, you just need to get out the checkbook and pay. So it's going to vary pretty specifically by state. We've been working on, a 50 state analysis. And so we've walked through that on all the various states, but it's going to vary by what your state law is. And it's also possible, it might even vary by your county. So in certain places in, again, California, but we also see that sometimes in Minnesota, where the counties have different wage hour rules than your state as a whole. In places like Iowa and other more sort of less legislation happy states, we tend not to do that. But there are places like Minnesota where they do. So you have to think about mostly not nationally, that's not going to be the issue. It's going to be your state. And then potentially if you have a separate county or even city regulation.
Right. And so most of the people on the call today have at least employees in Texas. So
Okay.
do you know just specifically about Texas at all?
Hang on, I have a chart. I'm very fond of charts. Hang on.
All right.
I am at the point now where I cannot keep all of it in my head. So it says in Texas that there's no statute that would require payment. So the issue would become, and this would be a question for their individual attorneys, right? Is there something in their history that would require payment? Is there something in a union contract, right? Is there something in their city or county? But it says that there's no specific requirement.
Okay, very good. Thank you very much. So would you walk us through the process, Dr. Pinkney, of a virtual test being proctored? So, you know, you've got a company, here's 1,000, take one of your colleges, here's 1,000 employees at one of the colleges, and they're going to choose to go to the at-home OTC with a test being proctored. How would that work?
Sure. So I recommend finding a company that can handle distribution and the telehealth portion, because again, they have to come together. You can't proctor a test if there are no tests. So that's the first point. So once you have the test kits, from a virtual standpoint, they need to have a HIPAA compliant, virtual care platform that can connect to your employee. You have a schedule, right? Let's say, we're testing Dr. Conard. He's scheduled at 11 o'clock. That medical provider would meet in the virtual room. It could even be a Zoom for that matter, because Zoom is now HIPAA compliant, or Microsoft Teams meet, and they would have the test ready to go. Now, most of these programs are going to give out instructions prior to the actual virtual visit, so that the employee has some sort of a clue on how the process is going to work. The instruction manual on these things are often quite lengthy. So typically these firms will have videos that the employee can watch, 3 or 4 minute video to understand the process, so they're not going in blind. The medical provider would then literally take them through the process step by step. Open the box, take out the reagent, take out the test strip, take out the nasal swab. All right, place the nasal swab into your nose a ½ inch, 5 circles, five rotations, each nostril. Place it in the reagent, place it on the test kit, so on and so forth, and literally walk them through the testing process. And then that test strip has to be in sight of the medical provider so they can watch it cure, usually 15 minutes, but every test kit is a little bit different. And then the individual will, sometimes we have them take a snapshot, or they can hold it close to the camera so that the provider can visually confirm the result of the test. And then that provider goes into whatever EMR they use, records the result, and then that result is uploaded into a dashboard that the employer can then view the result.
Got it.
Dr. Conard, can I raise just one small issue with that?
Of course, yeah.
So as far as I know, in Texas, you do not have a statute that would impact this. But if you have multiple business sites, there are a couple of states. And Dr. Pinkney, it sounded like employees might be able to access like scheduling and stuff on their own cell phone. Is that right?
Yeah, a lot of these programs, they have a mobile app, desktop.
Okay.
Most of them have to have a way for someone that doesn't have a smartphone to be able to access it. So most of them do have just a URL that any desktop or computer can access the software.
Okay, so in Texas, the mobile app or asking employees to put it on their phone works. In Iowa, that works. In other places, if you have multiple sites though, so like in Illinois, if you ask employees to download an app onto their personal cell phone, that can mean you have to reimburse them for the cell phone. Okay, so you want to make sure that by state, you're also not running afoul of these employee reimbursement rules, right? And so again, Texas should, as far as I know, Texas should be fine. Iowa, a lot of other states, but there are a few states that have very broad reimbursement requirements. So that would, as long as they have the URL or they could come to a central site to do it, that would work. But just if you have multiple sites, just make sure you're checking that issue too.
Yeah, that's a great point. So when you guys are selecting your virtual providers, make sure that they don't just have an app, because a lot of companies just have an app now that's on a phone or an iPad. You want to make sure that it's accessible with some sort of computer, a desktop, just a virtual URL. They can log on from any device and be able to access the virtual.
Okay, cool. So what is the general kind of range of charges, and what would you recommend the companies think about with regard to that proctoring portion? Do they charge that on their regular insurance as a 99213 visit, and so it doesn't have to be a separate line item that they have to come up with, or what do you see people doing? Yeah,
so it depends on if the company you choose takes insurance or not. So a lot of these companies are cash pay, because this is kind of a brand new industry, right? No one's ever done virtual COVID testing before. So a lot of times it's going to be a cash pay price, and they're not going to want to document and get a CPT code so that you can go bill insurance, because that's a whole nother ball of wax and a whole nother challenge. So when I'm seeing companies, because we've been doing this for 18 months, in-person visits for someone to come on site, run a test, antigen or PCR, could be anywhere from $100 to $200 per test when you're going on site and doing this. At scale, you could see that price come down to $65, $70 a test. And on the virtual side, you're looking at anywhere from $30 to $50 for a company to perform a test for you. So a lot cheaper than in person, but you're not. It's about the same as a telehealth visit, because this is time. So that person proctoring the test has to be on there for at least 20 minutes, and usually it's a 30-minute block. So you're not going to be able to get away with a $5 to $10 fee for 30 minutes of time because of staffing costs. You also have to remember that healthcare in particular, everyone's having staffing issues, but healthcare in particular, there's a huge issue with non-accessible RNs, LVNs, medical assistants, because COVID has just ravaged our industry. I mean, there's burnout, people are quitting. Travel nurses and hospitals are paying $120 to $150 an hour for staff. And companies that don't have big hospital budgets can't even begin to afford that. I mean, I made $100 an hour when I was an ER doctor, and there's literally, and good for them, nurses making $150 an hour right now. So the market is completely crazy, and it is something we've never seen before.
Yeah, well, and I can tell you, just in my personal practice, the cost of the lowest level person in our practice has gone up by 33%, just for the lowest level kind of receptionist MA person. So it is totally changed the dynamics of what we're doing. So if anybody has a question, we have time for probably one more question. If you can just unmute yourself and shout it out or type it in the chat. Let me just, while we wait to see that, I would say to you all, thank you so much. Oh, good.
So
Stacey.
Tricia had a question in the
Good.
chat about is there a list of these virtual providers who are ready and available to help companies?
The answer to your question is it's being collected. And I know that many broker consultant firms, I know many of you all work with either Stevens or with Holmes Murphy, are collecting those, particularly in your geographic region. So you can check with them, and and Danita and I continue to do everything we can to pull the list together to be able to hand off to you all and to go through that process. So we'll continue to give you lists and then check with your broker for sure. I see another question here. Can you expand, Dr. Pinkney, on how do you, can someone learn to proctor the test?
Yeah, so that's a great question. We didn't hit that point. So the third way to do this is to have a company pay them a consulting fee to teach your staff how to proctor the test. And in most states, you just have to have a high school diploma to be able to run actually a CLIA waived test, whether it's a analyzer-based test, point of care test, or in the case of an OTC test. We could teach someone that just has a high school diploma how to do that. So that's a great question. Way less expensive than bringing in a firm to virtually proctor the test or on-site test. So great question. Appreciate that.
Joellen, do you have any
raise
advice? Yep.
Can I raise one issue about that? You absolutely can train people internally to proctor a test. One thing I want to say is if you do that, you need to make sure you're developing first of all, they have to be masked the whole time. Okay. And because you never know if somebody's going to be positive, and you have to develop a policy where if they test positive, they have to be immediately removed. And then you have to direct them to either go see their doctor or something of that type. You don't want to miss that piece, right? Where you say, and you should seek medical care, because you end up in this sort of odd position where you've given them a positive test result and you want to make that cut very clean. So we don't provide treatment. We don't do any of that as a company. You need to go see your physician. That helps protect their health and safety, but that also helps protect us from them claiming that we have to pay their medical costs. Okay, so just make sure you're super clean and clear when you cut that off.
Great point, Joellen. And one more addition to that. the virtual testing program that you go with will also tell you the same thing, that performing the test and rendering medical care are two completely different things. So don't expect them to tell you what to do after that positive test. That's a completely different service.
Right.
Fantastic. Well, I want to respect everybody's time. You guys have been wonderful, just as I knew you would be. Just consummate professionals who I appreciate all that you do and the great service you provide the companies that we work with. So hopefully people reach out to you if there's any way that you all can help them. And with that, I'd like to declare this complete, and thank you very much for joining us today.
Thanks, guys.
Thank you.